Aloha and welcome to Point-Counterpoint here on ThinkTech Hawaii. And I want to invite everybody to listen well and actually submit your questions because this is our interactive program, letting people know what's happening in their communities and about issues that are important to them. Let me begin by first of all telling you that today's focus will be on healthcare in Hawaii, what's good about it, what needs to be improved, and how we can all participate in making that happen. We have as our guest this morning some very prominent individuals, starting first with Hilton Rattel, who is the CEO of the Healthcare Association of Hawaii. He will be joined by Dr. Scott Grosskreutz, who we will be now referring to from here on in as Dr. Scott. And Dr. Scott is a practitioner from the island of Hawaii. Joining Dr. Scott will also be Dr. Esther Smith, who also practices on the island of Hawaii. And finally, our citizen panel includes Vicky Cayetano, businesswoman, and just a very perceptive citizen. I want to invite at this time Hilton, who is the CEO. Tell us a little bit about healthcare in Hawaii and also what's happening in our state legislature.
Thank you very much. We are very fortunate to live in a state like Hawaii. According to Wallet Hub, in a 2022 survey, Hawaii is the happiest state in the nation. So we're number one of all the states in the nation. According to the Kaiser Family Foundation, in 2022, we have the healthiest population in the nation as well. In terms of life expectancy, we have the highest life expectancy of any state in the nation. Now, we don't do really well on everything. In mental health, for example, we're ranked 27th, so we're in the middle of the pack when it comes to mental health. And there are some other areas in which we don't do as well. But we have many things to be thankful for, and one of them is the legislative session this year. There were some significant initiatives that were supportive of healthcare. There was a total of $30 million that was appropriated by the state legislature for loan repayment. This is for physicians, nurses, social workers, and other healthcare professionals. In terms of professional fees, there is $13 million allocated from state general funds for January through June of next year, and $30 million for the following fiscal year, that along with a federal match will bring a total of $109.5 million into the state of Hawaii for physician reimbursement. And what this physician reimbursement does, or what this initiative does, is closes a gap between Medicaid and Medicare reimbursement for all physicians for the next 2 fiscal years. In addition to that, there was a total of $12.8 million over the next 2 years allocated for nursing facilities. So that's an increase for nursing facilities to help get their reimbursement up to cost. And there were material capital improvement projects that were funded this legislative session as well. Hilo Medical Center received $50 million. Kona Community Hospital received $18.5 million. The HHSC Kauai region received $23.2 million. Maui received $59.9 million. The HHSC Oahu region received $8.5 million. The HHSC state received $27.5 million. So the total capital improvements projects that were funded in this legislative session were $215 million. Now, healthcare is very expensive, but these are dollars that are very much needed, and the overwhelming majority of those capital improvement funds are going to the neighbor islands. Thank you.
Thank you, Hilton. Okay, let's hear from the neighbor island doctors. Scott, Dr. Scott.
Like Hilton mentioned, there's been some real progress this last legislative session that we're very grateful for. But some of the challenges that we face in the state of Hawaii is that many of the healthcare providers that are in part responsible for those excellent national statistics are in very short supply. That's not only physicians, but nurses, APRNs, PAs. According to the University of Hawaii, there's about 3,000 full-time equivalents physicians caring for our entire population. And that number is about 750 short of how many physicians we should have. And we've had shortages as high as 40 to 50% of the doctors missing on Maui and the Big Island the last several years. And Kauai is missing about a quarter of the doctors they need. And unfortunately, when you don't have enough healthcare providers, this shows up often as excess deaths or increased mortality. And in the state of Hawaii, we have significantly higher mortality for quite a few disease processes on the neighbor islands, including cardiovascular disease, cancer, COPD, suicides, trauma, adolescent deaths. So that really adds up. There was a nationwide survey of the 3,000 counties throughout the United States. And of the 3,000 counties, Hawaii Island had the third worst shortage of primary care providers in America. Maui was number 5, and Kauai was number 13. As a challenge, in addition to that, when you don't have enough healthcare providers, you often will see patients have adverse outcomes. I'm a breast cancer specialist, and in our mammography clinic, several times a month, we see women coming in that often have had a palpable mass for as long as half a year or more, and they just can't find a healthcare provider to refer them for care. And unfortunately, by the time they present, a lot of these women, have advanced disease, and the cancer is spread to the lymph nodes. So that's a real concern. The other challenge we have is that we really have the second oldest physician workforce in America. About 20% of physicians in the state of Hawaii are past retirement age, and on the Big Island, a third of my colleagues are past age 65. And so I've got colleagues who have themselves had strokes, heart attacks, cancers, yet they continue to practice because there's simply no one else to take care of their patients.
Isn't that what happened in Molokai recently when Dr. Aluli passed away and the other doctor that was there? I mean, when that happened, there was nobody, right? I mean,
yeah, that was a real challenge, Governor. And unfortunately, one of the Dr. Dang Akiona, who was in training at the family practice residency in Hilo, an excellent physician, she's starting up a practice there, which I think is tremendous on Molokai. And she's concerned about her ability to stay in practice, but this is an opportunity, again, for locally trained, healthcare providers to care for the community.
Well, I guess the point I just want to clarify this because of the statistics that you used. You said we're about 750 doctors short statewide, and with a aging workforce actually on the medical side. But isn't that is that 750 doctor vacancy evenly distributed throughout the state, or do we find a situation where Oahu may want more doctors, but in reality, the burden is much more so on the neighbor islands? I live on Oahu, and I never had a problem finding a doctor, and that's my point. I don't know whether there is a kind of neighbor island Oahu distinction. Statistics may be worse actually on the neighbor islands than they are here on Oahu.
Kevin, you're correct on that. We have something of a two-tiered system. On the neighbor islands and the rural areas of the state, most of the care is provided by providers in family practice and in private practice. And of course, if you're on Oahu, there's some excellent hospitals, a lot of tertiary centers, and that's wonderful. We're happy for that. I unfortunately developed a cardiac arrhythmia after a recent COVID infection, so I've got to go over to Honolulu to get a cardiac procedure done. I'm grateful that I can do that in the state rather than having to fly to the mainland. But on the other hand, we have far too many people with primary care challenges that aren't able to, have a physician or an APRN on the outer islands, and they have to fly routinely for primary care practice issues. And many times they have difficulty affording that. And a lot of times they can't take the time off from their work and their family to do that. So the idea of flying over for most care on Oahu is very burdensome to a lot of people in our population. There was a recent access to care study in the state of Hawaii that asked patients, how big of an issue is accessing care? And there was 20% of the people that responded said that they were thinking about, leaving their home island or even the state to find access to care. The same survey asked how the provider workforce was doing, and fully half of the healthcare providers that responded said they were thinking about either leaving medicine, leaving the state, closing their practices, or reducing the number of hours they're working. So, we clearly have some challenges that we've got to work on.
Dr. Smith, you would be reinforcing some of these issues, but I know that one of the areas that you were really interested in explaining and talking about was pre-authorization. So here we got a situation where there's shortages, and in addition, I guess you got to ask people on where Honolulu,
Research has
who
shown
decides whether you can, whether somebody can be treated in a certain way or not. Oh, how does that all work?
authorizations are required for numerous procedures and for medications. The burden of these things is such that when you consider provider time, authorizations don't actually save the system money. This is extra important in Hawaii, where we're already suffering from the severe shortage of providers that we have. I had a patient who had a bone tumor in the last year. We would have to get prior authorizations to do things like get PET scan. And we get prior authorizations for travel. And all of these things cause delays. So in addition to there not being enough specialists, so there's delays in seeing those specialists once you have the appointment and you have the authorization, these things are additive. And in the end, it took us 8 months for this tumor to be removed.
Who is the prior? Who or are? Maybe my wife, who's an English teacher, will correct me after seeing this.
Well, it would
Who is or are these people who give you the authorization or don't give you the authorization or take up time doing it?
There's not just one system, which is part of why it's as complicated as it is. One of the things we all take the most exception to is a system. Oh my goodness, I'm going to get the name wrong, but it's for our radiology procedures. And when we need to get a prior authorization for a radiology procedure, sometimes you fill out a form online that has a lot of check boxes and it's just authorized. If your check boxes have not added up in a way that satisfies the insurance company, you then actually have to call in, which is time consuming, and then talk to a provider, if we're lucky, eventually to a provider to do a peer-to-peer review. And I've had these reviews at times where I'm talking about fairly specialized care, and I can tell the person on the other side doesn't even have the vocabulary to talk about what I'm asking for.
Is this prior authorization being done by somebody with the same level of competency as you have? I guess that's really the question I'm trying to ask.
The answer is sometimes. A lot of it is me versus the computer, especially with the medication prior authorizations. You have to just have the check boxes that say you've done the things that the insurance company feels you should do before you prescribe the medication that you actually want to prescribe. This functions in a couple different ways. It encourages providers to choose the medications that are on the formulary, even if they're not the best medications for their patients, because it avoids the time of doing the prior authorization. Further, they make these things complicated by saying, oh, okay, you want this new medication for your patient that we know is better for migraines, but you have to prove that they've already tried these 2 other medications and you have to be able to explain how long they were on them, when they were on them, what went wrong. And sometimes these are things that are like 20 years ago, and you have to actually go back to your patient and ask them the questions, which again, I think you'd rather I was seeing a new urinary tract infection or treating somebody else's diabetes instead of spending my time interacting with forms online.
Got it. So anyway, this is obviously affects your practice and what Dr. Scott. So Vicky Caetano, our business person, among other things, sitting here. What do you think of this? I mean, as you're listening to all of this, what's coming up for you?
You know, that's what I hope we talk in the next 35 minutes that we have left. It's not just about the shortage of physicians and other healthcare workers. What I'm concerned about, what I see my friends and family are going through, is the changing face of healthcare service today. And what I mean by that is exactly what Dr. Smith brought up about now the requirements of pre-authorization. Who approves that? Well, frankly, it's the insurance company. You make your case as a doctor, but the doctor no longer is the decision maker on this. And insurance companies are driven by the bottom line. They may be called nonprofit, but let's be honest, it's a business. So my question and hope for discussion today is this changing face of healthcare that is happening now? I mean, you look at it, the primary care, your family physician, who is that today? Okay, we used to have a family physician, but now he's part of a whole system. We don't get to see that person. It's whoever is available. Is there equitable access for all people? Let's be honest. The answer is no. And this is why people on the other islands do not have nearly the access to the level of care that they deserve. It's interesting that I heard Dr. Gianrico Ferrugia, the president and CEO of Mayo, speak at an event. And he devoted his few minutes that he was speaking to the inequitable distribution and access to healthcare in this country. So it's not just Hawaii, it is this country. And I found that very interesting that of all the things he could talk about, he said that as healthcare professionals, we must make that pledge to our people that we need to address this disparity that is happening now. So my question is what we are seeing, this changing face of healthcare, really better for the patient?
Is the idea of doctors going to work for hospitals as opposed to being private?
Lack of support for independent physicians. There's really virtually no incentive anymore to set up practice, between the general excise tax that they have to pay, the cost of doing business in Hawaii. And this has a domino effect to everyone. When our employees have to take off 2 days just to go to the neighbor island, just to come to Oahu from the neighbor island to get to see a specialist, it impacts the business, it impacts them and their families. Who pays for their airline ticket, hotel, all of these things. So I'm not sure everybody understands it's not just shortage, but what concerns me is the changing face of the healthcare profession today. And I'm just thankful that we have this forum here with all the experts to talk about that.
Well, let's ask one of the experts. Hilton, you're the CEO of the Health Association. So, what's happening with this change that the Vicky's talking about? Well, I mean, it seems to us the reason we have great statistics. So I wouldn't want to live in Tennessee, who, if I remember, was way down on the border, and their problems might be worse. But even in the state that was rated #1, something's happening that's of concern. So, what do you think of this issue?
We absolutely have disparities within the state, and it's disparities between different ethnic groups and different geographical areas. And we're very, very concerned about those disparities. That's one of the most central issues that we're addressing as a healthcare association, working with our members. The statistics overall, as I pointed out, make us look very, very good. But when you look under the covers, and Dr. Scott talked about this, we have a bimodal distribution. On one end of the spectrum, we have predominantly Asians and Caucasians that do very, very well in regard to health outcomes. At the other end of the spectrum, we have Native Hawaiians and Pacific Islanders who could be 2, 3, or even more standard deviations away, or have lower, worse outcomes than other parts of the population. So that's a huge challenge. Now, going back to the issue of corporations or large employed groups versus independent practices, that's a challenge that is being faced across the country. Healthcare has gotten much more complex over the last 20 or 30 years. There's a lot more rules, federal and state rules. There's a lot more regulations. There's a lot more payer requirements that payers have, and the doctors have been talking about that. So it's very challenging for an independent practice or for a small group practice to actually focus on patients, to hire employees, to pay the rent, to pay their insurance, to pay their malpractice, keep up with all these rules and regulations. And also the demographics are changing as well. When you look at doctors who came out, graduated 20, 30 years ago, or even 40 years ago, when they graduated, they expected to be able to, be on call, to round on patients in hospitals, to be on calls on weekends and in the evenings and on public holidays. A lot of physicians now, they don't want that. They want a better work-life balance. They want to work 8 to 5. And so we've got a lot of factors that are at play here that are really changing the practice of medicine, as Vicky pointed out.
Well, I'm going to leave you to be the home run hitter on this start, because I really want to get to Esther and say, Dr. Smith, what would make, as a private practitioner, what would make life better for you in, I guess, Kona, right? Is that where you are?
My office is in Kealakekua, but yes, essentially Kona.
So what would make, as an independent practitioner, what would make life better? I mean, what would make your
I don't think
practice
doctors
better?
have changed that much in what we want, the career we want, or our level of commitment. It's that things have become so complex that you can't just submit your own paperwork. You actually have to hire somebody to do your billing. It's impossible otherwise. 8% of everything that comes in my door goes to my biller because it is too complex to be able to just get paid. And that's a decision we've made as a country, as a policy decision, that we should allow that to happen, that we have allowed it to become that complicated. So if we could simplify all of that, that would allow us to see more patients. I think many doctors would like to be in private practice if it wasn't so administratively horrible. Also, people who are in private practice cannot have the same grants and tax exemptions as the large nonprofit corporations that do healthcare. My tagline at my office is where you know your doctor and your doctor knows you. I think you're going to find that that's a hard standard to find in one of these larger facilities. And
This is very interesting because, well, Dr. Scott, I mean, I think you share much of this conversation with Dr. Smith, but you the reason why you're being asked now is that you kind of you served in both situations. I mean, you ran the hospital medical unit and you worked in the private unit. So how does what you did and what you're doing now and what Dr. Smith's doing, how does that all come together?
Yes, I have to say I agree with Kilton's comments. There's a need for strong hospitals and for well-developed tertiary care centers. I did serve as chief of the medical staff at Kilo Medical Center and trained over on Oahu hospitals when I was an intern. I see the need for that. So we're grateful for the support for our rural hospitals coming up. But at the same time, I think there's a tremendous need in the community, especially in our rural areas and underserved communities, for private practitioners. Because private practitioners like Dr. Dang on Molokai will go and set up clinics in places that the hospital simply can't afford to go because it's not cost effective. And so anything we can do to keep our existing private practitioners, there, so families can keep their primary care provider. So your children can keep their pediatrician, or you can keep your old OBGYN. That is just so important. And there's certain things we could do that are really logical. As Esther was pointing out, the average healthcare provider in America spends 15 hours a week wasting their time on pre-authorization procedures. The American Medical Society just sent a letter to CMS, the administrator, saying, hey, listen, 90% of physicians are saying they're seeing bad outcomes, from prior authorization, and up to a third are saying they're seeing dire situations like permanent disfigurement, death, hospitalizations because people didn't get care in time. And to CMS's credit, it's stepped forward and they're going to come up with ways to try to manage some of these, pre-authorization abuses. Hawaii is one of the handful of states in the United States that doesn't have any law whatsoever, trying to rein in or provide some level of balance, to the pre-authorizations.
We are we're one of the states in the nation that doesn't put a limit on the amount of time that whoever the insurance company or Medicare or Medicaid or anybody, whoever is authorizing a payment, can take as much time as there's no limit. I mean, is that what you're saying? I mean, I want to really be clear on that.
Yeah, there's a statewide survey that the AMA released, and there's no legislation in the state that mandates. For example, the AMA recommends that if something's routine, that it be approved within 48 hours by a specialist in the same field as the referring provider in the state that's coming from. And they recommend that if things are urgent, to be done in 24 hours. In Hawaii, often these decisions are being made by someone thousands of miles away in an office who's never met your patient and doesn't really know very much about them. So yeah, we do have a lot of room for improvement in that area.
So, Hilton, what's the association? Is this something that the association is thinking about doing something about, or is this something that's not necessary in Hawaii? It seems like both Dr. Smith and Dr. Scott have a problem.
Well, as a healthcare association, we represent hospitals across the state, nursing homes, home care agencies, hospices, and assisted living facilities. And we focus on issues that our members bring to us. So we're, again, a state association. All our members pay dues to support the association. And so every year we do a survey, and we're actually about to do a survey right now. So we do a survey in the June, July timeframe to help tee up issues for the next legislative session. So that survey is about to go out to our members for the 2024 legislative session. We did a survey last year. We do a survey every year of all of our members, and we collate all those issues. So if our members feel very strongly about this issue or any other issue, then they bring that to us and we rank those and then we focus on those. So we're working on issues all the time. There's lots of issues in healthcare. There's lots of priorities. We had very appreciative, again, of the money that we're getting from Medicaid. You know what, going back to the issue of disparities, one of the reasons we supported this Medicaid increase in Medicaid reimbursement for physicians, and that when we talk about physicians, we're talking about MDs, DOs, we're talking about psychologists, psychiatrists, nurse practitioners, physician's assistants, anyone who bills on a professional fee schedule will get the benefit of that money. And so it's $30 million a year in state funds. There's a $43 million a year federal match. That's $73 million a year. And that is just for physicians who see Medicaid patients. And the reason we pursued that particular option is to address very specifically the disparities, because there are significant problems with access for Medicaid recipients. And if a physician does not see any Medicaid patients, they will not get any benefit at all from this $73 million a year. It's only those physicians who see Medicaid patients who will get that increased reimbursement.
Well,
and so that initiative was designed specifically to address or help address health inequities within.
I can see Dr. Smith just chomping at the bit.
Grateful for the increase from the previous Medicaid levels up to Medicare levels, but you should know that we are dead last in the nation for Medicare acceptance. If providers could make an adequate amount of money to keep their clinics open on Medicare fees, then we'd have a higher Medicare acceptance rate than we have. So while I'm grateful for this increase, it's not remotely going to be enough to keep people open.
And you're chomping at the bit, Dr. Scott. You know, and I heard you say once in our many conversations that Alaska was getting 150%. It's got 50% increase in the amount of federal dollars that they got because of access to care in Alaska. So there was some kind of discrepancy in that.
Yeah, Alaska and Hawaii are both challenging states to practice in because people are, you've got a population that's scattered over many islands that are, or many areas that are geographically separated from each other. Costs are higher. The University of Hawaii just did a study on the cost of practice in Hawaii. The average primary care practice costs almost $500,000 to keep open. And as Esther said, often, Medicare reimbursements just barely break even. And then the state of Hawaii comes in and taxes the general excise tax on gross revenues, which can cost the average practice $20,000 to $30,000 of additional taxation every year on Medicare, Medicaid, and TRICARE. No other state in the U.S. does that. I mean, most of the time when states want to bring an industry in or attract an industry, they give tax breaks. They don't have unique tax, punishing taxation. And, I was really happy that the Hawaii State Senate and every House and Senate committee that heard the GET exemption bill voted for it, not a single no vote. It just never got heard by the House Finance Committee. So I don't know what to say about that. We must have spent 1,000 hours lobbying for it, and we were kind of hoping for 10 or 15 minutes to have it heard.
Well, let's hear what the citizen panelist thinks about that. What do you think about the fact that you as a person who is passionate about supporting private practitioners, what do you think about the fact that private practitioners have to pay an excise tax on an already low reimbursement system, and while the corporate, I shouldn't say corporate, but while the hospitals don't?
Yes, that exactly. This is what I mean about an equitable system. I agree with all the reasons why people today don't necessarily want to go into private practice. I get it. My point simply is, why do we add one more nail to the coffin of the disappearing independent physician, who I'm convinced 99.9 is really looking out for the patient? I'm not exactly sure of that from the insurance company's perspective or the larger hospitals. And it's not that they're not caring for their patients, but they have a different standard that they also have to adhere to. So I get it, but this is why you need a balance of both.
Well,
but tell me why they are having to pay the general excise tax. What is the logic?
I'm with you. I don't understand that. I actually looked up it's HRS. What was it? It's in the statutes. HRS 237, section 23. There's a bunch of exemptions to the excise tax, and there was some conversation that the reason why the hospital or the hospital systems actually didn't pay the excise tax, which I'm grateful that they don't have to pay it. Don't get me wrong, but was because they were nonprofits. Actually, it turns out that that's not necessarily correct. They're specifically exempted. It says hospitals don't pay this tax, but then it doesn't say. It seems like they were targeting the people who were providing the service as opposed to the service itself. By that I mean I have to get on a high horse a little bit about this. These are all Medicare, Medicaid, insurance payments for services rendered. They're the same service, whether or not you're in a hospital getting the service or in somebody's clinic getting the service. And yet one is taxed and the other isn't. And it's based on who's delivering the service as opposed to the service. It seems to me like if there are any lawyers listening to this, and I was not necessarily the smartest kid in my law class, but there seems to be a huge inequity in that kind of approach. I mean, is
It's
this something, Hilton, I guess, since you're the guy that has to deal with these types of issues, is this something that we should be getting more excited about, or even Scott, anybody?
I will add this comment. The current trajectory, I fear, is that the small, the doctors and nurses, the dentists providing, care in the communities in private practice are going to be mostly gone in 3 to 5 years unless things change. And when that happens, there will be no private practices providers left to tax with again. In that case, the revenues from GET on healthcare are going to go to zero because the hospitals are exempt. And we'll be missing a lot of healthcare providers that could be providing, income tax and corporate tax and property tax and all the rest of it. So it from a financial point of view, it doesn't really make a lot of sense to me.
To the state. So I guess that this is one issue we seem to have achieved unanimity. Well, there's another one though that sort of bothers me. So I'll throw this out. I had a great conversation yesterday with one of my doctors, and he what he was telling me was that he when he went to medical school, all medical professionals, even but especially doctors, spend an awful lot of time getting educated, which is good. I mean, I'm not going to knock that. You go to 4 years of undergraduate, 4 years of medical school, so many years of residency, and even if you're a nurse, you go through more than average. So all of the professionals, but the problem is the cost of education these days is so expensive that, and his point was that he was talking about, his daughter who's going to medical school. He was fortunate enough to have a daddy who paid for a lot of her expenses. But she has classmates that are rounding off on the 400,000 plus uh, in loans and payback expenses. And she said, the difference between the two, between her daughter and her friend, is that her daughter is like, she's going to charge out there, and she really, I don't care about all this money stuff. I want to save the world, and which she's very proud of. But there's no way in the world that her friend can do that. I mean, he needs to become a businessman. He has a $400,000 stake to play. What can we do about that issue? I mean, it seemed to me like if we wanted doctors to come to Hawaii or stay here in Hawaii, we ought to develop a program that makes it possible for, when I was in college and getting these loans and stuff, as long as I worked in government, every year they would take it down by 10%.
I think the solution is actually reimbursing at such a level that it's sustainable. I don't see that there is any moral advantage to providing reimbursement only in the form of loan repayment. There's such turnover in some of our clinics because people come here, do their loan repayment, and then they leave because they can't buy a house. We wouldn't need these large grant projects to fund our hospitals if our hospitals got paid enough per service to be able to take care of their hospitals. The reason why that they have been disintegrated the way they have is because they haven't been adequately funded. But nobody can take a chunk out of adequate annual funding. But you sure can make some people, some donors happy with a large project. Like, if you pay people for providing care, they can provide care, which is mostly what we want to do. We just want to take care of people. But I shouldn't have had to defer my mortgage for 6 months last year.
Just to to say how I can relate to your comments, Governor. My daughter and my son-in-law are both physicians, and they're in training programs. She's finishing up a Mohs surgery program, but by the time they get done with college and medical school and internship and residencies and fellowships, a lot of people are coming. They're not getting ready to enter the workforce until their early 30s. They don't have a dime in retirement savings. They have very little money in the bank. They've got loans that, even if they get help from their parents covering their college, etc., they're still $400,000-$500,000 in debt sometime. And we would love these people to come back, but I mean they have to figure out some way to pay the loans off. And Kilt has mentioned the state of Hawaii is kind of stepping up with a program to help with medical loan compensation or repayment, and I think that's great. But in the long run, I think Dr. Kelly Withy from the Area Health Education Center said it best. To paraphrase her, you could train 1,000 medical students in effect in the state of Hawaii, but if they can't afford to stay in practice after they graduate, you're not going to keep them long.
Absolutely. That's the point. That's part of what Vicky was talking about too. Is that if you can't, if the it's not just if the only place you can go to work to pay off your loans is with somebody that pays a salary, as opposed to you're having to scratch every month to just make a living. What possible future that the private practice has? But I'm hoping Hilton has a suggestion for us.
I absolutely agree with Esther and Scott in regard to Medicare reimbursement. We have some of the lowest Medicare reimbursement rates in the country for physicians, and Medicaid reimbursement, unfortunately, is pegged to Medicare, and commercial reimbursement is also generally pegged to Medicare as well, or at least is in many cases. So if you've got lower Medicare reimbursement, then you've also got lower Medicaid reimbursement and lower commercial reimbursement. Now, Scott was talking about what Alaska has, and Alaska was very fortunate. There's I don't want to get into the weeds here, but there's something called a work gypsy, and it's a geographic practice factor. And Alaska got an adjustment a number of years ago, and Senator Inouye was instrumental in helping Alaska get that adjustment. We have lobbied and are continuing to lobby with our congressional delegation to get that same adjustment for Hawaii that Alaska already has and has had for many years. We've calculated the benefit that would happen if that were to happen. And it's material. It would have a material impact, because one of the fundamental issues we're talking about in terms of access and retention is physician reimbursement. And the Medicare fee schedule is core to much of that fee schedule. So we went to our congressional delegation. I know Scott's been over there to DC. I don't know if Esther has been, but we have been talking to them for the last few years. There is a solution. They need a vehicle. It can only be approved by Congress. So our congressional delegation is aware of it. We've given them all the data. We've given them all the formulas. We've given them all the information. They support it. They need the right vehicle, and so that Congress can pass it. If we were able to get that reimbursement, that would even further increase Medicaid, and it would have an impact on Medicaid and commercial reimbursement as well. So that is a critical, tangible factor, and we need to continue, all of us need to continue to work with our congressional delegation, talk to them, and convey to them the value and the importance of increasing that work gypsy.
Well, see, this is why this is the part of the discussion where we start getting into my world, right? And so I understand and I get excited. Yes, people listening to this broadcast talk to our congressional delegation. Let Senator Schatz and Senator Hirono and Congressman Case and Congresswoman Tukuda know how important this issue is to the people of Hawaii. That if you want to go down in history as being as good and as great and as you all are, as the Senator Inouye of the past days, get us 150 plus reimbursement scale. This is a little commercial that I'm throwing in for in federal government. Now Go ahead.
Alaska's numbers, their like Medicare acceptance rate at the time at which they got this increase was not as bad as ours is now.
Right, we're worse. We're worse, and we have more justification than they do. And by the way, for those of you that have friends in the legislature who are listening, hey, come on, guys, look, hospitals don't get taxed on Medicare and Medicaid and insurance. And by the way, if you die, this is what really bothers me. I'm going to be a little bit of a pontificate in a sense. What bothers me is that if you die and you have bought a life insurance policy and you give it to your beneficiary, they don't pay excise tax. Okay? But if you do a service for somebody and you get paid for saving their life and you're a private practitioner, you pay the tax. Does that, I mean, the whole thing just no rhyme or reason. It just doesn't make sense.
Please also remember that the salesperson who sold you that policy pays like half of 1% on their commissions. So the value of a salesperson is greater than an independent physician.
That's what's, that's why Vicky and I on the show, because we can't figure out. So, we're going to take a few minutes to just try and figure out some of the illogic about all of this. Guys, we got about 4 minutes left. I'm going to start with anything quick. Hilton, you want to pontificate about?
I would just like to reinforce that solution, what is called the work gypsy, which is the increase in the work geographic practice factor for physicians. That is something that Congress has already approved. It's in place. There's a precedent for doing it. It would have a material impact on physician reimbursement and retention and recruitment in the state of Hawaii if we're able to get that through. Thank you.
Scott?
Well, I appreciate everybody talking about it. We've got some problems. They certainly can be solved. Many of the problems are pretty low-hanging fruit. They should be instantly recognizable, and solutions should be sought immediately. The other thing, though, is healthcare inflation is considerable. It's actually above the CPI in some studies. And even though healthcare and premiums for the local insurance industry have been going up over years, many of the healthcare providers haven't seen any increase in, say, their payment on capitation programs for 4 or 5 years. I mean, and the healthcare workers are the ones that are actually providing the healthcare. So just in terms of fairness and what's necessary to keep people keeping their primary care doctors and their pediatricians and their obstetricians, that has to happen.
Dr. Smith?
I want everyone to remember that provider fees aren't what we take home. It's what keeps the lights on and what allows us to have employees. And that in the end, we're small businesses that are being taxed at a higher rate than any other business in Hawaii. Only state in the country that does this. And it was 30% of my income one year was what I paid in GE taxes. And I don't think that's ever what the legislature intended.
Thank you. And Vicky, you got it.
Let's help our physicians build sustainable models. And, we need to make noise about this because health is wealth. Without this, we are a poor state. And please, let's not forget now that we have a leader. The head of our state is himself a physician. Governor Green is from Hawaii Island, so he knows these issues. And we can talk about legislators and, our congressional delegation, but let's not underestimate the power of the governor of the state of Hawaii. And let's make a noise also. I'm sure he's very empathetic to this.
Well, I think that what we really need is to get our community back of all of this and make sure. I mean, there's some very straight in. I mean, I'm looking at least 3 issues that seem to have solutions out there. I mean, number one, getting the pre-authorization system a little bit better organized. Number 2, removing the tax on excise tax on medical reimbursements for private practitioners. Number 3 getting to be at least as good, treated as nicely as Alaska, and the reimbursements from the government side. Number 4, finding a way to offset college costs. By the way, that's something we need to do for a lot of other professionals, not just the medical part. With that, I want to thank all of you for participating and tell you that we really enjoyed having you. I am really excited that I got to meet you, frankly, and I know Vicky shares my thoughts on that. So thank you for participating. Thank you for bringing this very important issue to the people of Hawaii, and we appreciate the work you do. Continue it, and maybe some good will come out of our conversation. Thank you. Aloha.
Thank you so much for watching ThinkTech Hawaii. If you like what we do, please like us and click the subscribe button on YouTube and the follow button on Vimeo. You can also follow us on Facebook, Instagram, and LinkedIn, and donate to us at thinktechhawaii.com. Mahalo.